We will find differences between arthralgia and arthritis. We will discuss about basic anatomy of a synovial joint, possible sources of joint pain which can arise out of any joint, and basic pathomechanisms of joint pain, and then the clinical presentations of joint pain and the various diagnostic possibilities, clinical examination of joint pain, joint aspiration and its inferences, means the findings of the, we will discuss the findings of this joint aspiration, and basics about radiology of joint pain, means possible findings in the patient of joint pain, and treatment options, various treatment options, and finally the principles of treatment. So arthritis and arthralgia, what is basic difference between these? So arthralgia is a layman's language. I have a joint pain. So any joint pain, and chiefly it is a symptom. Arthralgia, technically it is any joint pain without any swelling, without any inflammation, and without any limitation of joint motion. While the arthritis is a clinical entity, means you make a diagnosis of that thing, and it is usually associated with swelling, tenderness, or some decrease in range of motion, or joint diffusion, or means these all four may be present or may not be present, means either one or two may be present. But arthritis is just a general pain, and arthralgia is just a general pain, while arthritis is a clinical entity which you make a diagnosis of that thing. So as few basic, we all know that the synovial joint has a basic components by in synovial joint, and the joint is encapsulated by capsule, strengthened by ligaments, and a synovial lining lining is there around the bone ends, and these bone ends are also covered by cartilage. So and the synovial fluid, it is inside the synovial cavity, which gives nutrition to the cartilage and the surrounding things. So why it is important? Because any joint pain may arise from any of these structures, means it may either arise from end of the bone, cartilage, synovial membrane, or capsule, or ligamentous reinforcements, or tendons, or any synovial fluid, any pathology in the synovial fluid also. Basically, there are two types of means we categorize joint conditions into two broad categories: inflammatory condition and non-inflammatory condition. Inflammatory condition is something which is associated with the inflammation, and clinically it can be differentiated from others, that the patient will have pain at the rest, patient will have pain during the motion, and it will be worse in the to start with, and with the gradual use of that limb, the pain will decrease, except in cases of say septic arthritis. So classical examples of inflammatory conditions are all synovial diseases, for example, pigmented villonodular synovitis, reactive arthritis, okay, and all connective tissue disorders like rheumatoid arthritis, Richter's arthritis, Beckett arthritis, these are, and the crystal arthritis. While the non-inflammatory conditions, they have mechanical problem. For example, in any joint there may be say foreign body ligament injury, meniscus injury in the knee also. Huh? So problems. So they are chiefly, means the pain is chiefly based pain. If the patient gives rest, then there will not be any pain. So classical examples are age-related degenerating conditions and osteoarthritis, traumatic conditions, mechanical fractures, mechanical problems also, and the post-traumatic arthritis also. Okay, DDH. So these are the examples of non-inflammatory conditions. So any pain from any joint, it may arise out of these five mechanisms. So patient may have mechanical joint problem, for example, meniscus injury, post-traumatic arthritis, or patient may have synovial inflammation, or patient may have inflammation or of the surrounding tendons and the ligaments, and there may be infection in the joint structure, or there may be something foreign body deposition in the synovial cavity. So these are the basic mechanisms. Clinically, joint pain may be acute, subacute, or chronic. Acute means something which is of very short duration, so less than 2 weeks. This timeline of 2 weeks, 2 to 6 weeks, or more than 6 weeks is little bit arbitrary and don't have any means basic logic. Any condition means there is vast overlap of the conditions in between all these three: acute, subacute, and chronic. So this is things. Acute is usually said to be less than 2 weeks, subacute is 2 to 6 weeks, and chronic is more than 6 weeks. And means there is vast overlap. For example, acute are usually infection, trauma, acute rheumatic fever. Subacute is reactive arthritis, SLE, sickle cell disease, hemarthrosis. They usually remit also in a short time also, and with the pharmacological treatment or non-pharmacological treatment. Or chronic arthritis is the connective tissue disorders. All the connective tissue disorders, monoarticular, polyarticular, or oligoarticular, depending on the number of joints involved. And sometimes, in some conditions, chiefly they pertain to medicine, the joint pain, it keeps on waxing and waning, and it keeps on moving between one joint to two other joint. Okay, so for example, in the rheumatic fever, the inflammation settles in a one joint and it goes to other joint. Joint involvement can be symmetrical also, while as well as asymmetrical also. So symmetrical is usually seen in rheumatoid arthritis or SLE, while asymmetrical is in rheumatoid arthritis, post-traumatic arthritis, reactive or Lyme's disease. Among the common causes of monoarthritis, so single joint is involved. Uh, Chiefly, they are infections. Infections usually happen in the one joint at a one time. Means it is very uncommon for a patient. We find a patient that he has infections in many joints, except neonates and small kids. Otherwise, they are an immunocompromised patients. Tubercular infections also, they are also uncommon in many joints simultaneously. Crystal arthropathies, they usually involve one joint or say two joints, but not more than not many joints. Pseudo gout, calcium appetite induced arthritis, and spondyloarthropathy, rheumatoid arthritis, they can also have single joint presentation in to begin with, but otherwise gradually the connective tissue disorders, they progress to involve many joints. But for example, rheumatoid arthritis is there. It is very well known that they start with a single joint. Other causes can be synovial diseases, foreign body, or amyloidosis. Among the non-inflammatory conditions, they may or may not be monoarticular. Osteoarthritis, internal derangements, cartilage derangements, or neuropathic joints or sarcoidosis. Okay. Among the polyarthritis and oligoarthritis, chiefly these are inflammatory conditions. For example, all connective tissue disorders, they cause either oligo or polyarthritis. Means, they may be having monoarticular presentation in the beginning, but at the end they end up with involving many joints. So how do we clinically assess, and what shall go in our brain while assessing any joint pain? So we need to differentiate between mechanical pain or inflammatory pain, and find out the exact location of that pain in that joint, or exact source of that pain in the either any of the joint. Means we will think in that direction. Probable etiology of that joint pain, and the deformity and disability which the patient had developed due to that pain. So means patient might be finding difficulty in doing activities of daily living, or some any other thing like sitting cross-legged, squatting, doing household chores. So these are called as disability. Clinic. So just to make a diagnosis of any joint pain, we require its a detailed analysis of that pain, pattern, times, proceeding events, or other systems or other known joint areas. So some suggestive findings in polyarticular pain. So raised silver plaques, they are classically in the psoriasis, and a patient having urethritis, arthritis, or mucous or membrane inflammations, diarrhea also means bowel gut inflammation, they are likely to have reactive arthritis. Likely, not mother sure. Then the patient has fever, then it is suggestive of infection. The fever may also be there in vasculitis or in the gout or rheumatoid arthritis also. Lymphadenopathy is chiefly with the lymphadenopathy is HIV syndrome or hematological malignancies. Oral ulcers, genital ulcer, Beckett syndrome, bony tenderness, and chest pains. They are in the sickle cell crisis, not in sickle cell disease, in the sickle cell crisis. Then the ulcerations, they suggest for vasculitis, tick bites, Lyme's disease. Patient has recent vaccination or blood product infusion, then it may suggest a serum sickness. We need to assess, other than the detailed analysis of pain uh, and accompanying symptoms, we require range of motion of each particular joint also. So any involvement of a joint will usually decrease range of motion. Any arthritis will decrease range of motion, except in cases of unstable joint or there is gross destruction of joint, in which there will be range of motion will be higher than the normal. Then the joint is the volume inside the synovial membrane. So synovial fluid is usually very minimal in amount in any joint. The biggest synovial fluid joint in our body is knee joint, and the normal amount of synovial fluid in the knee joint is less than 4 ml, usually less than 4 ml. While in case of disease or any affliction, the synovial fluid will either synovial fluid or reactive fluid, it will increase, and the and the joint volume will increase. So there are two possibilities for any increased volume of joint. For either there is hypertrophy of the tissue in the joint, or there is increase in the mass of the joint, tissues of the joint. For example, in neoplasm or synovial hypertrophy, or say pigmented villonodular synovalitis, or there can be increase in the synovial fluid. The synovial fluid may be normal or will always be abnormal, not normal. So there are few conditions which says, there are few clinical signs rather, which says that the pain is a difficult one and it require an urgent attention, and it point towards an emergency situation. So if there is pain is associated with local rise in temperature, local erythema, either at a small portion or in a diffuse area of that joint, or there is the effusion develops very suddenly, or there is acute multi-joint involvement, then these are the danger signs, or say that red flag signs, that they require urgent attention, okay, to diagnose and to treat. So joint pain will require investigations. So with routine investigations like complete blood count, ESR. The CBC may show anemia of chronic disease, hemolysis, if any, for example, in sickle cell disease or hemolytic anemia, serum sickness also, leukocytosis in, sorry, or increased WBC count in case of septic process, or leukopenia, for example, in SLE or in other rheumatoid disorders, or reticulocytosis in sickle cell disease. There will be increased turnover of sickle sickle cell formation. ESR is usually increased in all connective tissue disorders and chronic disorders, and but classically it is decreased in sickle cell anemia. Other investigations, for example, rheumatoid factor anti-nuclear antibodies, anti-dsDNA, ASO titers, and CRP, throat swab, X-ray, CT scan, MRI, synovial fluid. Other specific tests are uric acid and urine examination, or any other depending on the primary clinical entity. So joint aspiration, it is one of the important diagnostic modality to ascertain diagnosis of any joint pain accompanied by effusion. So joint aspiration is only when indicated and only when there is clinical effusion. Clinically there is joint effusion. So with the help of joint aspiration, we see cell counts, crystals, cultures, and cytologies. These four things we try to see in every joint aspirate. So these are analysis of various types of joint fluids, the basic analysis. So in normal in normal joint fluid is clear and transparent with a high viscosity, means not like water, it will have high viscosity, and WBC count is less than 200 ml, 200 per cubic millimeter. And among these WBCs, the polymorphonucleosides, nuclear cells, PMN cells, leukocytes, they account for only 25% cells. While if in case of any pathology, these WBC counts they increase, and the polymorphonuclear cells their proportion also increase, or it varies. So the classical non-inflammatory conditions, for example, osteoarthritis, mechanical problems of joint, in those conditions, the synovial fluid is usually within the normal range, or there may be slight WBC count increase, and it will be slight WBC, means 200 to 2000. While in case of inflammatory conditions, there will be exponential rise in the WBC count in the synovial fluid, and it will be more than 2000 to 50,000, or even say 75,000, or even 1 lakh also. And among these WBCs, this proportion is important. The proportion of PMN cells, it will increase from normal 25 to say more than 50%, or even 75%. In case of septic arthritis, this number of cells, WBC cells and the PMN cells, it will be very high exponentially. The color of the septic arthritis fluid, it may be sometimes it is clear, and it may be dirty or yellow. It is not necessary that classically it will be seen as just like the classical pus, that thick yellow purulent pus. Okay, and while in case of hemorrhagic joint effusion, it will mimic blood. So X-rays of all these conditions. Just a minute, excuse me, just a minute. Just excuse me. Yes. So X cartilage loss, chronic inflammation. So each of these entities, although they are interlinked. So these are suggested by few X-ray signs. For example, this patient of this X-ray of both the knees, it suggests there is loss of cartilage, there is loss of joint space. So loss of joint space is depicted by either there is cartilage loss or the meniscus has also decreased in its height. So there is loss of meniscus height and there is loss of cartilage. That's why these two joints are touching each other. There is no joint space, and there is periarticular sclerosis also. These white lines. So it also suggests that the bare bones, they are rubbing against each other and the cartilage has denuded nearly complete. The cartilage is denuded. So this rubbing of two bare bones is called as hibernation, and this chronic rubbing will called subchondral sclerosis. And if the condition goes on chronically, then there will be osteophyte formation at the margins. For example, these sharp beaking, okay, in the edges, and these are osteophytes. And if the inflammation persists for long period, then there may be subchondral cyst also. For example, in this area this is visible, in this area one of this area of radiolucency is visible, in the periphery this is also visible. Okay, this X-ray of hand, it is showing periarticular osteoporosis, and this periarticular osteoporosis chiefly suggests chronic synovial inflammation. There is the joint lines are also not very clear, they are touching each other, so there is some cartilage loss also. So the hand is non-weight bearing joint, hand has non-weight bearing joints, and the knee has weight bearing joint. So both behave slightly different when in presence of the pathological processes. In case of infection, the chief presentation will be lysis and sclerosis. The osteophytes, and they may or may not be there. Osteophyte is always there only in chronic condition, not in acute condition. Infections are usually acute, and even if it is chronic infection, then depending on the chronicity and depending on the focus of infection, the area of infection in that joint, there will be presence of lysis and sclerosis. For example, in this X-ray, the chief involvement of only medial condyle of tibia as well as femur, while the lateral part of the joint is chiefly spared. The joint space is maintained, and the cartilage itself, this cartilage is there, and there are no cyst and sclerosis. While in case of middle side, there is a cyst also, subchondral cyst in the femur, and there is bone loss or bone lysis, sorry, in the medial condyle of tibia. So these findings suggest non-contagious finding, means non-continuous findings. So these suggest uh, infection, and around that infection there is sclerosis also. This white. Post-traumatic conditions in these means they occur after a malunited fractures. So in those conditions also there will be sclerosis in around that joint, but there will be evidence of a heel fracture or a malunited fracture in form of these fracture lines which has gone blurred, and there will be cortical irregularities, and there will be depression in articular surface. There will be the cut and the evenness of the cartilage surface of the joint surface, it will be destroyed. So this patient has means probably an fracture of proximal tibia along with fracture of proximal fibula, and which has malunited with a joint depression, and the femoral side is almost normal in the, provisionally normal. So it treatment of this any joint pain, it will require a combination of things means physical modalities, then physiotherapy, pharmacological treatment, and the surgical treatment. So it is algorithm based usually. Hmm. So among the physical modalities, they are protection by anything, either rest or brace, sling or wrap, or ice application, compression or elevation. These are usually applicable for acute conditions, not for chronic conditions. And then the physical modalities, depending on General measures require activity modification. For example, a patient of osteoarthritis or say rheumatoid arthritis, he or she may require activity modifications just to avoid pain in that joint, or a exercise program, and to ascertain that joints are flexible and mobile, maintain function of limb, and prevent any deformities which are developing. And physical modalities are ultrasonic therapy, shortwave diathermy, continuous passive motion of those joints. Uh, Local injections do help sometime in inflammatory conditions, and they are absolutely contraindicated in presence of infection, for example septic arthritis. Pharmacological therapies, uh, combination of pharmacological therapies which are possible for joint pains are topical medications, oral medications, NSAID, opioid COX-2 inhibitors, topical capsaicin, menthol, methyl salicylate, DMRDs in connective tissue disorders, glucosamine, colchicine, and allopurinol, antibiotics, pain modulators, antidepressant, depending on presence of accompanying symptoms and the pain perception by patient, and steroids, either oral, local, or injectable, and biological agents in various connective tissue disorders. Among the surgical procedures, various surgical procedures which are possible in joint pains are surgical drainage, for example, if there is any septic process, acute or chronic septic arthritis, or synovectomy if there is involvement of synovium. For example, pigmented villonodular synovitis, it requires excision of synovial membrane. If there is malalignment of joint, then it may be treated by any osteotomy and realignment of that limb. I will show you these X-rays later on. Then the excision arthroplasty, if there is means infection or say acute very painful arthritis which and due to damaged joint which is beyond, which cannot be reconstructed by any other method, and joint replacement, one of the most common method of joint reconstruction. Arthrodesis, in specifically in the non-weight bearing joints, for example wrist, ankle, and shoulder, also the fingers, also finger joints also, they are also treated by arthrodesis. Soft tissue procedures, sometimes the connective tissue disorders, so these periarticular conditions, they cause neurological complaints also, and other mechanical problems, for example trigger fingers, carpal tunnel syndrome, nerve entrapment. Now we will have small few words about osteoarthritis. So osteoarthritis is the most common joint disorder. Is the most common joint disorder, and these X-rays they show shoulder, TM joint, sacroiliac joint by osteoarthritis. So basic pathology is the repair mechanism of bone and cartilage gets changed. There is more of damage than the less of repair. So this derangement of repair and the attrition, it results in the osteophyte formation at the edges of bone, cartilage attrition, and bone cyst formation. So what happens? Basically, the process starts with the articular cartilage derangement. Then initially the articular cartilage gets eroded at some point in the joint, and this articular cartilage damage, it progresses in such a way that the subchondral bone is exposed. Initially it starts as a fibrillation, just a small flake of cartilage is taken off the bone, and then it progresses to become a fissure, then a tear, and then they once this through these tears, the synovial fluid it seeps inside the joint, and with the load bearing, this synovial fluid, it cavitates inside the bone and makes a cysts, small cysts. So, what a patient with osteoarthritis will have cartilage loss with exposure of bone, underlying bone. There will be synovial inflammation. Joint space will also decrease since there is cartilage loss and the other surrounding meniscus and they are also damaged. At the edges, there will be formation of osteophyte and there will be subchondral cyst and sclerosis. So there are two major types of osteoarthritis, primary and secondary. Primary, when there is no known cause of osteoarthritis, and secondary is when there is any cause of osteoarthritis, identifiable cause of osteoarthritis is there. For example, in post-traumatic conditions, or for example in or any other connective tissue disorders or anything else through which we can identify any cause of. So primary is idiopathic and the secondary is due to something else. Risk factor for osteoarthritis: the patient means elderly patients with female, chiefly female gender, obese, and with a family history overuse of joint. For example, sports persons, they also tend to have arthritis. The micro trauma to cartilage, it is bound to progress over a period of time to become a full-fledged osteoarthritis. So a patient of osteoarthritis or OA, the pain will be usually first symptom, and there will be joint stiffness, joint swelling. There may be joint bony crepitus. Yes, they will happen after at some point of time. Joint crepitus will also appear, uh, and the alignment of limb, it may also change, specifically in the lower limb. So the X-ray findings and the clinical findings, they usually do not match. A patient with a uh, major radiographic findings, he may be having minimal symptoms, while a patient with minimal or nil radiographic findings may be having many symptoms. So these do not correlate completely. So diagnosis of arthritis is osteoarthritis is usually clinical, and X-ray findings, they just supplement or augment the primary diagnosis, clinical diagnosis. And blood investigations also are usually don't have any role in establishing diagnosis of means OA, and uh, because OA is a systemic disease, not a systemic disease. So all blood parameters which are usually deranged in chronic joint disorders, for example, ESR, CRP, urine analysis, they will not be affected by osteoarthritis. Synovial fluid is more or less normal, or it may be used to exclude other diseases. Just a minute, excuse, just a minute. So sorry for interruption. So synovial fluid is examination in osteoarthritis is usually normal, but the cell count will be not very high. It will be near around the normal, 200 to 2000 per cubic millimeter. But sometimes it is used to exclude other diagnoses, for example, septic arthritis, gout. So among the four classical findings, radiological findings, these are joint space narrowing. There will be osteophyte formation. These curved round is newborn formation. So these are osteophyte. This is osteophyte, and there is subchondral cyst, for example, this, and there will be subchondral sclerosis. So these are classical findings of osteoarthritis. Fourth finding is osteoporosis. So that joint will be not normally used. The use of that joint will be less. So there will be disuse, osteoporosis of that joint also. So how do these subchondral cyst, osteophyte, and subchondral sclerosis become? So once there is cartilage loss, the bone to bone contact between two articulating bones, it will also increase. And if this increases, synovial fluid is under pressure, is forced into defects in the articular bone, and this untrapped synovial fluid, it causes subchondral cyst. Additionally, there will be compensatory newborn formation deposition at the edges in the other non-weight bearing parts. In the non-weight bearing part at the edges, which are not weight bearing. So these will call these will result in the osteophyte formation and the subchondral sclerosis. Uh, Kellgren-Lawerence grading scale. So this is used to this staging is used to stage osteoarthritis. So this is chiefly a radiological staging. So grade 1, 2, 3, and 4. So these are X-ray of grade. Among these, grade 1 has no features of nearly a normal X-ray, while grade 2 have minute or small osteophyte, for example, in this X-ray at the edge, and grade 3 will have definite osteoarthritis in the central spine also and the peripheral also. But joint space will be normal, signifying that the cartilage and the in between structures, for example, meniscus, they are still present. While grade 4, there will be loss of cartilage, there will be loss of meniscus, and there will be subchondral sclerosis as well as the osteophyte. So osteoarthritis may be due to age-related changes, rheumatoid arthritis, gout, septic arthritis, or many other diseases which are possible. They may be in the differential diagnosis of OA. Arthroscopy is needed only when the clinical diagnosis is doubt and the usual treatment line is not giving any relief. Arthroscopic treatment of that. So arthroscopic diagnosis is usually not done only when it is combined with a treatment only. So, for example, this patient of knee has a normal meniscus with a normal femoral condyle and normal tibial condyle. The cartilage visible is normal near. In this case, there are fibrillations in the cartilage on the femoral side, and there is definite loss of cartilage on the femoral side and it is on the tibial side also, and the meniscus is also not normal. Treatment planning of osteoarthritis. Treatment planning is done uh, chiefly. There are three or mode three steps rather. So it is an algorithm based. As a first line of treatment, patient is taught about exercises, education, and weight control. While gradually we add first and second line as a pharmacological pain relief or medicines we add, and if anything do not give any relief, then the um, surgical modalities or other invasive modalities they are added. So the general measures required they include patient education, lifestyle modification, ergonomic posture, the posture correction, and the physical therapies. Range of motion exercises, muscle strengthening, short wave diathermy, or transcutaneous nerve stimulations. Among pharmacological treatments are the analgesics, either oral or injectable, or steroidal as well as non-steroidal. And the topical analgesics, they are usually nearly placebo. Capsicum, methyl salicylate, or NSAIDs, they uh, usually don't work well, but just give the effect of placebo. Or intra-articular anti-inflammatory medicines, for example, corticosteroids or lubricating agents like hyaluronic acid. Among the surgical methods which are used for osteoarthritis are arthroscopic debridement, uh, bony realignment surgeries, and bone replacement surgery, depending on the pattern of involvement. So, arthroscopic debridement is used only for usually for early cases or only when there is diagnosis is in doubt. Then the bony realignment surgery are done when the alignment of limb has changed. For example, in osteoarthritis of knee, there is loss of cartilage on the medial side, usually in the, so the real that with the help of high tibial osteotomy, the tibia is realigned in such a way that weight is transmitted through the lateral part of joint rather than the middle part. The middle part is damaged, so the weight is transmitted through the lateral part. So this is a diagrammatic representation of high tibial osteotomy and the proximal metaphyseal osteotomy for realignment of tibia. And then the bone replacement surgery, one of the most common for advanced degenerative disorder, uh, damaged or osteoarthritis or destroyed parts of bone, they are replaced with a metallic parts. So just to conclude, arthritis and arthralgias are part of a big spectrum of clinical entities. There is, they require a clinical evaluation for exact diagnosis of the clinical entity, and treatment usually consists of two parts: symptomatic treatment and disease specific treatment. Osteoarthritis is most common joint disorder, and diagnosis is chiefly clinical and which is assisted by radiography. Treatment is algorithm based and depends on and consists of general measures, physical therapy, medical therapy, and the surgical treatment. Thank you. So with this, we conclude our class today. I'm not I'm not sure how can I get your questions and answer your queries. If any one of you have any query, I can solve. If they can write me mail or through your CR or even write in a chat. So we conclude. Okay. Thank you.